I'm going to discuss long-term care with you a little bit, and then Dr. Brady's going to jump into managed care. I think I'm going to give you a scenario to think about while we're discussing this. I brought it up to a class for Miss Hunt last week about a place where I worked, just so you can get a real-world scenario. And I'm going to bring it up first because I want you to start thinking about this location as we kind of go through the next, 20 slides, because something that occurred negatively in this location applies to every slide I have out here, okay? So that's the really general statement, but you'll figure it out. So let me tell you a little bit about a place in Arkansas that I worked. So this was a long-term care, 120 bed long-term care and SNF skilled nursing facility. So we were duly certified, okay? And which means that we were able to bring people in for rehabilitation services, and then if they needed long-term care, they could stay in there, and those beds automatically converted, duly certified beds, okay? And in this location, when I call it a project, I took the project on, it's been 7 years ago is when I took it on. And I actually got there at the end of March 7 years ago, 2012. Is that right? Yeah, trying to picture this, 2012, or was it, I don't, it's been 7 or 8 years. It feels like an eternity sometimes. Sometimes I feel like it's been yesterday. But and when I got it, it was on what they call the National Focus Facility List. Have I mentioned that before? Okay, so anyone aware of what the National Focus Facility List is by Medicare? Okay, this is the list you do not want to be on, okay? It's a national list of those facilities who are in danger of losing their Medicare licensure, okay? They're no longer going to be certified as a skilled nursing facility due to regulation violations, multiple complaints, problems with outcomes, and this is not the list you want to be on. Let's just put it that way. Once you lose your funding, you're in trouble, right? Your reputation alone can take a hit as a facility just by being associated with multiple surveys. And then after multiple surveys be placed on this list, it's pretty bad. If you get the opportunity to go, just you can Google it, National Medicare Focus Facilities. And it'll give you the current list of all the facilities by state. And you can track through that, all of the deficiencies that they have, okay? So it's a really bad place to be. So I take this place on, right? 120, like I said, 120 beds, so it's a fairly large facility. Here's the kicker. This place had only been open for about 5.5 years when I got it. So in 5.5 years, you go from being newly certified, licensed, and fully operational to the threat of no payment, losing your ability to take care of residents. So how does the question I have, first question I have, how does a person who is being discharged from the hospital know where to go? This is the maze, right? This maze right here. This is, how do you know what a good location to go to is? What's your best resource? So in the hospital, they give you some resources, right? They have case managers, and they say the physicians are saying that you need additional care after the hospital. We think you're going to need home health We think you may need some type of outpatient care, or we believe that you need additional inpatient care. Additional inpatient care can come in a lot of different ways, though. So you're talking long-term acute care as a possibility. You're talking skilled nursing. You're talking your basic nursing facilities, meaning long-term care nursing, assisted living. You could end up with inpatient rehabilitation, which obviously is not on the maze. There's a lot of different areas that you could end up. How do you know where to go? Which one to choose? That's the problem, right? That's the problem. How many of you have even know everything about each of these locations, right? I don't even know everything there is to know about each of these locations. And I've worked in this now. We were looking yesterday. I've been in this for about 10 years. And that's hard to swallow as somebody that most people would consider an expert. What about those who don't work in that field, right? It's completely difficult for them to make those choices. And so when someone says, yeah, you need to go to a skilled nursing facility, that's usually where you go because it was recommended by a physician, right? And physicians are the ones that supposedly know what's best for you. So you're going to take their word for it. But there's a lot of factors that play in, okay? All right. So I'm going to jump through. We're going to talk about the concepts of long-term care. Going to go through the main services, who needs it, why, and then the different types of services that are available, okay? And then I'm going to talk to you about some of the specialized services. Pretty lengthy list. Okay, so I'm talking about specifically about nursing home and skilled nursing. So the problem is the typical patient does not know, for example, that skilled nursing is not inpatient rehabilitation because nursing homes do a really good job. They spend a lot of money. Not going to name the name of the facility that I worked in, but it was whatever health and rehabilitation center. Okay, not anywhere in there does it mention anything in regards to long-term care, nursing homes, nothing. That's how they spend a lot of money discussing that rehabilitation. The percentage of beds that are utilized at one given time in a duly certified facility are very few. You're talking roughly a quarter to a third of those total beds are being used for skilled services, rehabilitation of some sort, okay? And those are the beds that are actually helping the facility stay afloat. And the reason is, and we'll dive a little bit more into this later, but Medicare pays more than Medicaid, okay? And we'll talk a little bit about why that is and why Medicaid is even in the picture, okay? So there are 7 main components. The first being that long-term care, as you can see by that ridiculous maze, right? There's a ton of services that are available. But within each service, there's a variety of services that are offered. For example, in let's just stick with nursing homes for the time being. In a nursing home, you will have just on the skilled side, you'll have speech therapy available. You'll have occupational therapy, physical therapy. You'll have other services that allow the resident or the patient to have the same type of interactions that they would in their own home environment. And so you think about the services that you have at your fingertips living in an in-home environment. The requirement is that these locations provide the highest level of care while also providing the highest level of freedom for the resident. That's why whenever I discuss resident and patient rights in our orientations, it's really funny. If you've ever read the actual patient and resident rights listed out by Medicare, those rights are lengthy, pages and pages and pages of rights. And in order for us to cover these with the staff, it's almost impossible. You take an entire day going through each of the rights they have and why it's a right. The best way to sum up a patient's right is that they have a right to everything. If you can make that choice in your home, then you have a choice to make, you have that choice available to you here in our facility. So the joke is the example I had of a patient in our rehab hospital about 5 years ago who requested with their meals every dessert that was available. And so we had options in our menu of 5 or 6 desserts that were available at meals. And so breakfast, lunch, and dinner, she received pie, cake, ice cream, and cookies every meal. She was diabetic. She also only took a bite of each of them and left them on her tray. Huge expense for the hospital, right? Not a huge expense, but it's a pretty good expense. It's a lot of wasted food. And a lot of people said, can we just tell her no? And the truth is you can't, okay? Because if she was at home, she would be able to select any of those options or all of the options, right? I mean, you can go home tonight, right? And you can have tacos. If you have them and you're right, you can eat tacos, and you can have cereal, and then you can, when you're done eating your tacos and cereal, you can go have a piece of pie and some ice cream, and then when you're done with that, you can go eat a whole carton a whole bag of potato chips, right? You have that right, correct? Not saying that you would do it, and nor is it healthy. And then the dilemma becomes, well, if this person's a diabetic, what do we tell her? How do we stop her? Still has the option. We can educate. That's all we can do, right? So a variety of services, a variety of things available, as much home-like environment as possible. Brings you to another component, which is individualized services, right? Our job as caregivers is individualized care to the individual. So you'll have what they call an IPOC, the individual plan of care for every individual that ever comes into your hospital or nursing home. And that job is to cater their recovery from their illness to their specific needs and to help them recover to achieve their highest level of health, which will require well-coordinated total care, right? It doesn't do any good if your physical therapists are fully engaged in making this plan of care individualized, and yet your nursing department treats every patient the same, right? Does every patient get the exact same medications? No. So there is a huge effort to make this well coordinated, because if your speech therapy department doesn't know what doctors are prescribing or what the food services are doing for meals with this patient, then the patient will, choke and die possibly. Okay, get the wrong diet, bad stuff. And like I said, it goes back to promoting full independence. So if we think of long-term care, it's pretty easy to think of, right? Extended periods of care in order to help them get back home. So this is long-term care, right? It's not acute. This is subacute, post-acute care. The requirement is that the patient is cared for as long as necessary. Okay? And that's the kicker, right? Start getting into debates with your payer sources on how this care, when the care should end, and you say, hey, this person needs 14 more days of care, and we believe we can get them to go home. And then the payer source says, we'll only give you 10. So, what do you do? hard, right? So this is a hard question. So you end up with someone who's not a safe discharge home, and sometimes you end up eating 3 and 4 days worth of care because there's no funding. Okay, that's how it is. You just eat the care. Sometimes you're able to do things like set up home health and set up a program with home health to help cover some of the needs, so that when they discharge at day 10, they can go home and still be safe and still receive some of the care that they needed. So there's no perfect care, but you can get pretty darn close. Okay. And the ultimate behind this is that we are trying to provide a higher quality of life. That should be the foundation, regardless of the location. Quality of life is what this is all about. Whether you're in long-term nursing home care, assisted living care, whether you are in a skilled nursing facility, inpatient rehabilitation, home health itself, you want to ensure that the quality of life is there. And your licensed and clinical practitioners are the ones that have the obligation by way of their licensure to ensure that the quality of life is being maintained sufficiently by their services. Okay. All right. So going back to the beginning of my little tale of this really rough situation in Arkansas. During that time while I was there, I'm sure the questions are in the back of your head. I know everybody was thinking this, right? Why was it on the list? And that's not what you're thinking, but I'm going to go ahead and throw that in your head. Why was it on the list? What could be the problems? So obviously we know that it's regulatory based. We know that there were findings through survey. But what was the extent of the problems? What's the root cause of all of these problems? So let me go back in time a little bit. So I get there at the end of March, and I have a staff of almost 200. It's like 196 staff members in this place. And nobody got along. Literally people yelling at each other, fistfights breaking out behind the building. Let me paint a picture for you though. This is a brand new basically facility, 5 or 6 years old, in the wealthiest part of Little Rock, Arkansas. I literally had a family member who was one of the financial advisors for the Rockefeller family. High levels of wealth. This also makes you wonder why they would stick their loved one in a nursing home, but that's a whole other dynamic, right? So I have staff members not getting along. And this type of treatment with one another had been going on for a while, and they allowed those feelings to navigate themselves into patient care. Bad situation. So what do you do in that situation? And that's a real question, not a rhetorical question. I'm curious, what do you do? And it sits solely on your shoulders, okay? You are the new executive director and you are responsible for it. What are you going to do?
Call an emergency meeting.
Okay, have a meeting. And what are you going to do in the meeting? Any ideas?
Lay down the law.
Okay, you can lay down the law, right? You're also going to discuss what you're seeing, right? You're going to explain, and first thing you do is you lay out the mission of your organization and help people understand what the mission is. We're here to provide high quality of care for each of these residents and ensuring that they get a quality of life that they deserve. And if you can't get on board with that, then we're just going to let you go. Okay, so you laid down the law. You have some people that voluntarily leave, which puts you in fine because hiring takes time, and now you're short-staffed, which in turn results in the state of Arkansas sending out people to investigate claims about why you're short-staffed. So you get surveyed for a week at a time. And their findings are, yes, you're short-staffed, and so they penalize you, and they charge you money, you have to pay the fees, and then they want your action plan of how you're going to increase staffing, and then what you're going to do to reduce your total number of residents in-house so that your staffing levels meet. So they're telling you to reduce your income and increase your staffing at the same time. That's a true scenario. Yeah. All right. In the process of digging into all this, you find out that none of your staff members really have any recollection of some of the things that they're being trained on every month. And so you dig in, you're like, why are they not getting up? Every month they have continuing ed that they have to do, and why are they not remembering all of these things that are being taught? So you dig in and you come to find out that your human resources director and your staffing coordinator who are married to other people, by the way, and then one evening you walk into a room in the back and you find out they're having an affair, and that's a whole other situation, but during the process of digging all these things out, you find out that they had come up with a plan to charge each of the staff members $25 in lieu of having the staffing coordinator just do their CEUs for them. Okay? And so in return, staffing coordinator and the HR director are splitting the money. So $12.50 a piece times 100 plus employees every month. It's a pretty good gig, right? Makes you realize why somebody's driving a really nice car, at the rate of pay they're getting. So what do you do there? You terminate, right? You have no choice. So you say, I'm sending you guys packing. I'm sorry. You knew better. Which in return results in both of them contacting the state of Arkansas and complaining about staffing levels and about, quote, unethical behavior on behalf of the executive director of the nursing home. So the state of Arkansas comes in and does an ethics violation investigation into yours truly to find out that obviously there was nothing there happened but waste a week of my time. Okay. And in the meantime, they find discrepancies that the HR director knew about in files, in HR files. But of course, the HR director knows the HR files are messed up because the HR director is the one who messed them up, right? So you end up with a problem. So here come a few more fines from this and an action plan on how you need to get your files up to date, and that none of your people have CEUs recorded correctly, and so there's an additional finding which results in you having to do massive amounts of education really quickly, which costs a lot of money. So I'm losing money like crazy, right? Okay. So the process of digging into these financial issues, we do a grand audit. So me and my business office manager decide we're going to dig in, and we say, let's look into all the financials for the whole place and see what we can find with all the resident accounts, make sure nothing is going on. And my social services director doesn't show up for 2 days worth of audits, calls in sick. For us to find out the social services director had been writing checks out of patient accounts to herself for whatever services and making money on the side, which results in having to notify state police and an arrest. And the organization I'm with is now in the news, which reduces the total number of admissions to our location because no one wants to go there because it's in the press about all these foul things going. So again, financial hits, reduction in resources, and I've fired another staff member. And because of this, I move on to my next location, which is food services. And we're auditing food services to find out that my nutrition director had not been filling out their dietary portion of the MDS, the minimum data set for submission of payment for our billing. And we were behind by 3 months. And so I put this person on an action plan, and nothing happened. And nothing got filled out. And so I missed 90 days of billing. So it's another further reduction in income, and resulted in firing of nutrition services director, which in turn resulted in staff members who had worked for this individual coming to me and explaining to me that this person had told them that she expected them to pay between 10 and 20% of each of their paychecks, or she was going to write them up and fire them from their positions. So they were each writing her a check for 10 to 20% of their paychecks every week. So this in turn gets turned over to the state police department for investigation, which results in more loss, more time in the paper, and less admissions. Which in turn results in fewer people wanting to work there, which means that my whole action plan of trying to get people in place was really, really hard. And then by this point, you would think light bulbs would be going off above everybody's heads and say, this is why this is on the National Focus Facility list, right? You hired a bunch of crazies to run your organization. So we cleaned house. In the 14 months that I was there, we had something like 146% turnover rate, which means I turned over some positions more than once, right? That's pretty scary. This is how not to run an organization. So at the end of 14 months, at the end of 12 months, we received notification that they were going to finally come in and give us our final round of surveys to take us off of the list. We had survived. We had survived the time I was there. We were getting our licensure back on track. We weren't getting penalties anymore. There was a point where I remember we were getting surveyed every week. Okay, and these surveys, they were off of complaints. People were complaining. Ex-staff members were complaining. Patient families were complaining. But, things that you have to change within the organization to make sure things stay up on par. For example, we got rid of our family council. A lot of you're only required to have a resident council. This place had a family council, and all it was for the first 6 months I was there before we got rid of it was a complaint session, and almost as if they thought they were the board of directors. And so I said, you know what? We're just getting rid of it. Get rid of it. It just feeds on itself. And things got better. Family relationships improved because I said, if you want to talk, just come meet with me personally. Don't make it a big forum and get other people riled up. Just come talk to me. And so we got things settled down, and we got it where things were okay. And then at the 12-month mark, when they announced they were going to come in for our final surveys, I put in my job application with Mountain States, and I moved to East Tennessee at month 14. So they got their licensure back, and I got my freedom back and said goodbye to Arkansas. I'll see you guys when I decide to visit. So there's a really condensed version of 14 months of just chaos. Literally getting phone calls at 2 a.m. from nurses who said, hey, Ryan, do you know where my paycheck is? I'm like, why are you calling me? Call your supervisor. They've got your paycheck. 2 a.m. You're just now thinking of this? Things like that. Just insanity. Okay? Lots of crazy stuff happened, but the reason I tell you this is because think of these different services that could be affected and why they are so important. So, for example, obvious services, medical services, right? If you're not providing good quality medical care, you'll end up on this list. there are federal regulations that are in place, state regulations that are in place in order for you to meet a minimum requirement and allow for a high level of care. Okay, these minimum requirements provide high level outcomes. Okay, mental health services. Think of the poor people who are stuck in an organization like this. They have nowhere else to go, and we're not able to provide mental health services. We have an obligation to do so, right? Other things, you're supposed to have social support, but yet your social services director is writing checks out of your account, you know, to pay for whatever vacation they want to go on. Therapeutic and preventive long-term care. So this is things like you start looking at even some Medicare Part B plans that can help you if you don't qualify for Part A services while you're there. Community-based institutional services. So community-based services would be things like senior centers, other services that are available, but your institutional services are always going to have the inpatient in-house where you are going to reside for a period of time, okay? Then you have housing, which is your assisted livings, but your end-of-life care, which is, to be honest, this is the best quality of care I have seen given. Hospice care is unlike anything else that I've ever experienced. These people that work in hospice care truly get it. They get it. They get what their role is. They know why they're there, and they give exceptional quality of care. The interesting thing is, by the way, that most of these things can be run together. So, for example, long-term care, you can have hospice care in-house in your long-term care organization. You can have hospice come in. In fact, I would advise that. Get a contract with hospice care of one or two organizations so that you can provide that in-house. Nothing more confusing to someone who's at the end of their life than to be moved all over creation, and not have the surroundings they're accustomed to. So obvious clients, long-term care, older adults, children, adolescents, young adults, people with HIV and AIDS. So I'll give you an experience I had in Chattanooga. I had a young man who was out with some friends, and they decided to go swimming and dove into the water without looking and ended up with a very severe spinal injury and required long-term care services for the rest of his life. So the dilemma here, think about the quality of care that you have to provide. You have a 20-something-year-old man who is placed in long-term care services in a nursing home, and you have to provide a quality of care comparable to his surroundings. Is that what he's accustomed to? No, it's not, right? So how, as an administrator, do you help meet that quality of life for that individual? Because you got to think, the average age for long-term care is Medicare age, right? Now you have a young man who's involved in this. So what do? He needs your services, but he also needs quality of life. There's a requirement to meet his needs. What do you do?
Probably want like a one-on-one, face-to-face meeting, because there's also probably going to be a generational gap there. So.
Absolutely. Yeah, absolutely. So that one-on-one meeting with family, with the young man, and say, we want to meet your expectations. What is it that you want out of this? How can we help meet your expectations and maintain your quality of life? We realize you've had a traumatic life event that changes things forever, but we want you to maintain those pure elements. So, some of the things we did is we provided an area for him when he needed to have friends and family come over, where he didn't have Alzheimer's patients coming in the room and interfering with his daily activities. I know that a couple of my sons came in a couple of times and played video games with him. He had he had his own room because nobody wanted to room with him, because he would stay up all night watching sports and movies. And at one point we had to explain to him, look, we got to get rid of the subwoofer, because it's really loud. So, but we were able to maintain those things regardless of the environment. But that is a requirement, okay? All right. So give you a general idea of the demographics. 1% less are roughly 1% are children 18 and under. 39% are working age adults, but you can see that Medicare segment there is the largest portion of those that require long-term care. As far as general care is concerned, maintaining your activities of daily living is the biggest portion of this. I hate when I see somebody come into our hospital and their diagnosis is debility. It just means that they've had this general decline in their overall health. And it's sad for me, because you think, what could we do to help maintain those things? I will tell you, if you want to live for a long time, you just stay active. Stay active. It's the biggest thing, in my opinion. Everybody that I know that, my wife's grandfather just died. He was 96, 93, and he died of cancer. But this is a guy, when he turned 90, went skydiving. That he's engaged. Stay engaged. You don't end up with a debility diagnosis when you're engaged. Your body is made to be exercised and moved. And so as an organization, your requirement is to help people stay moving, okay? It's really pretty funny, right? How many of you have spent any time in any type of long-term care location, just visiting? So what did you see?
People walking around.
Walking around, what else? You see any activities going on while you're there?
Mm-hmm.
Yeah. They do all kinds of activities, just anything to keep them moving. Anything that you saw that you just really thought was interesting or that you liked? Not a thing. I don't blame you. I tell you, one of my favorites was balloon volleyball. Was always a personal favorite. Nothing better than a bunch of people in their wheelchairs playing balloon volleyball. And it's really interesting. Half of them have oxygen or nasal cannulas in place, and they're going at it, and they have a blast. But that helps keep them engaged. Helps remove that percentage of the population. Remove that percentage of chance that they will end up being that part of the population with a debility diagnosis.
One of our graduates, I think some of you guys in Preston, artist, posted a video of him and his patients doing the baby shark, which was hilarious.
I haven't seen that.
And they were all dressed with bow. I don't know. They were all wearing, costumes and stuff, and we're all doing baby shark.
That's awesome. It's really a lot of fun. If you ever want to really feel like you have a lot of impact on individuals and get to know people, long-term care is where it's at. That's the one piece of this part of the business that I really miss, is being in long-term care, because you develop some really great relationships with people, and it's pretty remarkable. So you have custodial care. That's just the maintenance of function, just helping people stay functional. You'd be surprised at how quickly it goes away. You go into any long-term care organization, and you will see people who have severe arthritis, for example, and they'll have carrots, the foam carrots shoved in their hands to help keep the contractures away. Sad stuff, and it's just to help maintain function, right? We have restorative care, so that's to help gain and improve. So what happens here is So what is the qualification for skilled nursing? Do you guys remember what the qualification for skilled nursing is? How can you be admitted to skilled nursing? So you have to have a 3 midnight stay in an acute care center, okay? And then have the order written for skilled nursing. So if you're only getting 2 midnights and they try to discharge you and you need skilled care, you're not going to get it. How many days of skilled nursing do you qualify for under Medicare?
60.
It's not.
100 days. You get 100 days, right? Okay. But you're right with the 60. 60 is part of this. So you have 100 total days, right? 20 of those days are without a copay, and 80 are with a copay. Now, what happens? You run out of days. You get day 100, and then you're out of days. When do you get new days?
After the 60.
After 60 days of what? This is pretty important. That's why I'm not going to let you off the hook. 60 days of what? Is it just 60 days that pass?
Discharge?
They have to be 60 well days. So you cannot go back with the same diagnosis to the hospital during that 60-day period. So, well period pays. So here's the thing. You use up 100 days and you're fine for 59 days and you get admitted to the hospital. You're out of luck. Who pays for it at that point? You do. It's all out of pocket. So, the reason they've come up with that scenario is that most people who have an event are not going to use all 100 days. In fact, it's really, really rare. What happens is most people end up using 30, 40 days, and then they don't stay well for but 45 days, and they have to go back, and they've used 30 to 40 days, and so they're automatically in a copay, and they have 60, 70 days that they can still use, but it's under a copay. So the best thing to do is try not ever to get sick, right? It's tough. That was sarcasm, by the way, in case anybody ever really want to know. It's tough. That's a hard place to be in that, right? All right. So when we talk about post-acute, it's all of the above. But subacute is post-acute with complex services. Does that make sense? Okay. All right, long-term community-based services. They are the least restrictive setting. Because think about it, community-based services, most of them are in a truer home or are in a home like situation. You could either be at home or an assisted living or retirement community. Some type of service will be offered to you. The goal here is to provide support, right? And prevent you from going into long-term institutionalized care. So another service that you can offer as a long-term care institution is respite care. But as a community-based service, that might be something that is offered to prevent you from going into long-term care. So it's, for example, I would have occasionally people would hit us up and say, we need someone to take care of our mom for 7 days while we were gone. And so take her into an Alzheimer's unit and keep her there for 7 days so the family can get a little bit of a break. And why are these services available? Why are these covered services?
Cheaper.
It is cheaper, and that's a portion of it. And think about the cheaper services Those are usually those home-based services that they're not institutionalized. So we want to keep people in those types of in that situation, right? So if you offer things where occasionally you have a caregiver who's a full-time caregiver, the burnout rate is really, really high. So if you offer respite services, it still keeps the cost down from a payer standpoint and allows that person still to stay home and with the caregiver getting a break occasionally. It's a really great service. And those respite services are usually organizations like, there are actually respite companies out there. I know of a couple out west that's what they specialize in. They can either go into the home and take care, or they provide a location. Some of these other services might be in a group home type environment where it's a literal home, 4, 5, 6 bedrooms, and each bedroom is dedicated to take care of an individual. Or someone can come into a nursing home and spend 7 days there and then go back home, where they know that they'll have activities, they know that they're going to get their nutrition services taken care of, medications will be administered properly. Lots of opportunities there. So if you look at all of these funding sources here for these community-based services, you see that a lot of these, while some of these may have federal backing, most of them are going to be state or community-based, okay? And it's because the federal government really is not involved in the idea of true long-term care, right? So when you go into a nursing home, your longest term residents are either going to be one of two types of payer source, have one or two types of payer source. They're either going to be private pay, which is extremely expensive, or they are going to be Medicaid. Let's get through that. You can read about those in your book. Those are not near as exciting, right? Just kidding. Okay, so let's talk a little bit about that part of it. Let me see if I've got a slide on this. Yeah, I'll get to that. All right, let's just jump over here. I don't want to spend a whole lot of time there. So let's talk about institutionalized care, and then I'll jump into the financing so that it makes a little more sense. So there's 5 main categories. You have subacute, independent, retirement, residential, and personal care, assisted living, and skilled. Where do you think the majority of these beds are located? Give you a hint. It starts with number 5. So skilled nursing, right? Most of your subacute is in skilled nursing, and really the true reason is not because of any other factor, but that it's the cheapest subacute institution. Okay? You have intermediate care facilities that deal specifically with those with mental handicaps, and then you have Alzheimer's facilities and continuing care retirement communities. So the CCRCs are less institutionalized and a little more in between the assisted living and your regular retirement center. So they might have some nursing services available. All right, let's see. So basically, there's been a huge decline in the nursing home business. We've become more averse to the nursing home industry over years. And there's a few reasons for this. Some of the reasons are medical based. We're much better now at helping people recover from illness than we used to be. And so long-term care is not not as required as it used to be. And so as this has happened, other locations like assisted living, home health services, they've all expanded. I mean, I don't think there's a single community now that does not have at least one or two home health services available as options when you discharge from a hospital. Whereas it used to be that was a rarity. So it's really expanded a lot. So 93% of beds are duly certified. What does that mean again? What kind of certification would you need? We're talking about nursing homes. So you have Medicare certified, right? And then you have long-term care certified beds. Okay, and so by saying they're duly certified means that those beds can be used either way. I can literally keep you in the same room, bring you in under skilled care, leave you in the same room, and your bed literally converts into long-term care. I can leave you in that room till the end of your days. We hope that doesn't happen, but that's what happens. So 93, why wouldn't all of them be duly certified? Why do you think there's that 7% holdout? What do you think that 7% is? Do you think those 7% are skilled beds, or do you think that they're long-term care beds? So it's a 50-50 shot. What do you think it is, right? Skilled beds, yeah, those are usually skilled beds. Great example of this is Princeton Transitional Care down the road here. They are strictly skilled. They cannot keep you. You go in there and you have really low level, under 3 hours a day of rehab, and then they send you home or to a nursing home. That's what their goal is. I like to refer to it as a cash cow, because there's lower overhead, you're not providing anyone's long-term care, and you are strictly taking Medicare funding or managed care funding. And when operated correctly, that is a lot of money rolling in. I tell you that because I used to run Princeton, and if it hadn't been for we took a high level of charity cases, and if we hadn't taken our charity cases, it would have been money hand over fist. Because you think about it, all you're doing are providing skilled services. Every service that you provide, you can bill for. Whereas in long-term care, you don't get the bill for every service. Okay. So if 93% of those beds are duly certified, you can convert to long-term care, and your average facility size is 107. That gives you a good idea of the total number of beds that are being used for skilled services. Just because you're skilled certified doesn't, I mean, you could, like for example, I had 120 beds, they're all duly certified. I could use all 120 beds for skilled, but the max I ever got to was close to 60, and that's about it. And especially you're running an 83% occupancy rate. I'd like to see a study. I haven't been able to find anything since 2012 that shows what the estimated occupancy rates are. But I imagine they've been declining, and I'll show you a graph on that in a few minutes, over the years. And so the total number of beds has been dropping as the years have gone by, just because of lack of need. And it goes back to those community-based services that are available after an acute care stay. And most of these are operated by a multi-facility proprietary chain. So your NHCs, your Grace Healthcares, your whoever's, they own more than one facility. And that's about pooling resources. It's like being part of a system. So here's a general idea of how the beds have decreased over the years. You can see that the Medicaid-only beds and the Medicare-only beds, there's quite a difference between those two. But your duly certified beds, that's a dramatic difference. But they have declined over the years. I mean, it's been a reduction in, you're talking 9-10 years, you're looking at almost a full 1,000 1,000 certified beds. That's pretty dramatic. So, occupancy rates, you see how those have declined in the over that 10-year period, and that's just a trend. That's a great trend. I mean, it really is. It's a great trend. I would love us not to have to worry about any of those, anyone having long-term care. Just get them healthy and send them home, and everybody's fine, right? It'd be great not to even need hospitals, right? All right. So if 90% of your nursing home residents are elderly, remember that graph I showed you where it was said 60% were 65 and older? I've had a lot of people ask questions about that. These do not, that 60% is talking about long-term care services, remember, okay? So don't get those confused on an exam that 90% of your elderly take long-term care services. It's only 60%. 90% of your residents that are elderly are in nursing homes. Got it? 90% of your nursing home residents are elderly, okay? That leaves that 10% out there of the guys like the young man I talked about earlier, okay? All right. Let's see, what do I need to jump in on? So some of the services that really focused on the obvious things, ADLs, that's a daily thing in a nursing home, okay? Every day something is being done, whether it's formal or informal, things are happening, whether it's having somebody demonstrate that they can cook, tying shoes, the things that we take for granted are being done there every day. Additional services, wound care, dementia care, and then different restorative services to help people regain their health. Other conditions that we deal with are depression, Alzheimer's care, and bladder incontinence. But this is the startling one. Over 25% of the patient population there use antipsychotic drugs. I think I have a graph. So if you look at the 25%, the goal is to reduce the number of this. This is a really big concern in the nursing home industry. Polypharmacy as a whole has really become a big focus in this industry because people are so overly medicated. And antipsychotics are a big part of this. So why do you think the big push has been to eliminate this?
Because the drugs can cause side effects, like it can cause them to fall and affect them in a negative way.
Yeah, so what seemed to be a quick fix in a lot of ways for a mental issue becomes an overarching problem, and can cause, like you said, falls. It can cause mood swings. It can cause loss of appetite. Increases the amount of time required for recovery from other illnesses and other problems. So really is not helping the person return back to that quality of life. Now that we are starting to become a little more aware of the mental side of things, the idea that we can use mental health care services to improve someone's quality of life, a lot of these things can go away because we are learning different interventions. We're learning different coping mechanisms and how to teach them. We're learning how to teach someone the signs of something that may be coming, so we can become more aware of how to handle it and prevent something from happening in an institutionalized environment. So that's the goal. As we recognize this, we have been able to really reduce the number of drugs that are being prescribed. The state of Tennessee requires a reporting every Monday on, for example, opioids, not related to these antipsychotics, but opioids, because of the focus on the drug problems that are already out there. Can you imagine having multiple prescriptions for painkillers in your medical record and available to you, and no one even thinks about it? So you spend half of your life, the remaining half of the remaining years of your life stoned out of your mind because they're just automatically giving you these drugs, and nobody's looked at whether or not that you need to be receiving them. So every Monday now, I get to file a report for any adverse reactions or any issues that our hospital may have had, and report it to the state of Tennessee, because that's how focused this has become. Okay. So, like I said, nursing home industry is the cheapest location. Which is why a lot of people go there. They have not increased the amount. In fact, Medicare reimbursement rates have gone down in these areas. So if you look at this and you shift into long-term care, your largest payer for long-term care, not skilled care, but long-term care is Medicaid. Because remember, I said you had two options, right? So you really have private pay. It's very rare to have someone that has a managed care policy that covers long-term care. They're out there, but I've never in 10 years seen one come into one of my locations. That's how rare they are. So Medicaid being the largest payer, and we know the differences between payer source, what is Medicaid paying for? So Medicaid pays for that maintenance of life, okay? That's what it's there for, it's pay for the maintenance of life. This is not for you're rolling down the hallway and you flip your wheelchair over and you break your leg. Medicaid is not paying for that. They're paying for you to be maintained in a long-term care facility. I believe the state of Tennessee's requirement is that you have to qualify financially for this if you're elderly, just like anyone else would for Medicaid services, and cannot have assets and financial resources above $2,000 in your bank account, basically. So they do what they call a spin down. If you're staying long-term care, you've been in there for 3 or 4 years, and you get up to $1,985, the business office will come to you and say, or your family, depending on who's responsible for your care, and say, we're approaching the $2,000 range. Is there something that you would like to buy, or would you like to buy your family member that they might need so that we can keep it below $2,000? And then that's when you see so-and-so in room 112 got a brand new recliner, or they got all new clothes, or whatever it may be, okay? It's to keep that number down so they maintain their qualification for Medicaid. Wouldn't it be really sad to lose your long-term care coverage because you had $2,007 in your bank account? For $2,007, you think you're going to be able to survive for very long? No. So it's kind of an interesting system, right? Now Medicare payments, the total number of payments have risen pretty well, but they haven't, the overall reimbursement, unless you meet certain categories, has not spiked, has not jumped dramatically. It's, in a lot of areas it's dropped. So what payment platform for reimbursement is used by nursing homes? So if hospitals use DRGs, what do nursing homes use? So they use what they call resource utilization groups, or RUGs. You'll hear people always talking about their RUGs. You know, I think the RUG system they're in now is called RUG 4. And it's built, those skilled services are billed by the minute. Okay? And there are different types of services available. And this could be an entire 2-day course on just skimming the surface on RUGs. RUGs, the way they're calculated is pretty crazy. You can have multiple services and it'll qualify you for a different type of RUG level. You can have separate RUGs that go together, and so you get to bill for 2 different types of services that don't go together. It gets kind of crazy. But know that the max number of minutes that you can get is roughly right under the 3-hour mark a day. And that's what they call the ultras, the RULs, the RUHs. Those are ultra highs and ultra lows. Once you're in that ultra level, you are at the highest level of minutes, and that's the bracket where you make the most money. I have, so when I was changing how things were being done at Princeton, one of the things I realized was that we had a shortage of therapists. And because we had a shortage of therapists, I wasn't getting all the therapy that we could make available to our patients. I couldn't get it out there. Most of my therapists spent all their time doing assessments and then just a little bit of therapy. And I couldn't explain that to some of my higher ups, that I needed more therapists so that I could get more therapy done and be able to bill for those minutes. And I'm sitting here looking at this like, it's right there in front of us, and we're not doing these people justice. We're doing the bare minimum. And so I put together this really wild spreadsheet and did some projections. And I said, look, if you can give me, based on this, I can increase profitability by almost $20,000 a month if you'll allow me to have 2 new therapists. And they're like, what? Show us the hard numbers on this, right? So I show them this whole presentation on the spreadsheet, and based on this, by being able to move someone, just moving them an additional 60 minutes a day with those individuals, produce that much income. So from an income standpoint, that's great, but also at the same time, you have people who are eligible for this type of service and they're not getting it. And so it lengthens their stay. And the goal is to do the maximum amount in the minimum amount of time, which is exactly what Medicare wants. Okay, they want you to get everything you can done in a small amount of time. They'd rather you run somebody up at all ultra highs and then get them home in 14 days than have somebody stay at a mid-level for 21 days. Okay, it's a cost savings to them, and it's, if you can keep patients running through, it's a big gain for you. So what do you think they did? You'd think they'd just jump right on it, right? And say, yeah, take here, 2 therapists, open up 2 positions. Nope. Later on I found out it's because they were trying to keep their numbers low so they could go through this merger. Yay me. So, all right. Private long-term care insurance, very slow growth. So like I said, 10 years, I haven't seen a single policy come through any of the locations I've been in. So for-profit facilities, some states have a mandatory staffing ratio that you must meet. I will tell you, Arkansas is leading edge on this. Arkansas has their own available app for nursing homes to use. You can go to the Arkansas Department of Long-Term Care Services. Their Health and Human Services Department in there has a section in there on long-term care, and there is something you can download onto your computer to find out if you are meeting their staffing ratios daily, because you have to report them every week to the state. And you just type it in. Okay, what's my census? I have this much of a census. This is how many people I'm required to have. And so do I have all of those people here? you already know up front if you're deficient or not. And so if you get the chance, go on their website, download it. I mean, it's a neat little quick tool to use, and it'll give you an idea of how many nurses you need, how many CNAs you need, and it's good to use in any state you're in, to be honest. I used it once I came back here just to have a general idea because I knew it would help me exceed expectations. Okay. Going back to ownership, we talked a little bit about that. So remember, the beds are dropping, the total number of used beds are being reduced, and so ownership is also down. And the reason is because there's not that many large conglomerates. They're all being bought up and becoming bigger, and these mom and pop places are being bought up by them, and so you can see that while not-for-profit or government locations have decreased, the biggest increase has been on the for-profit side. So they have lower ratios of staff, they have lower staffing ratios, but they're maximizing what they're doing with that so that they can clear profit. And that is all I have. Any questions for me? Man, I must have just done a great job explaining all of that. All right, you guys want a break? All right, how much of a break do you want to give them, Dr. Payne?
5-10 minutes, and then we'll come back.
Okay, sounds good.
So, never a dull moment in health services management and policy, right? So did you guys pay attention to a 2-sentence statement that came out from the Attorney General? No. Okay, so Texas versus U.S. So if you guys remember, a judge in the court systems in Texas, so some attorney generals from Republican-leaning states, or pretty much from Republican governors' offices, put forth a case against the Affordable Care Act. And they were pretty much saying that the individual mandate is unconstitutional. And so by a kind of like, so if that's unconstitutional, and that's one of the important parts of the Affordable Care Act, then therefore the Affordable Care Act is unconstitutional and should be null and void. Like, that should, like, mean that the Affordable Care Act in total should be scrapped. And so that is not really where even Republicans want to go in the House or the Senate. Because as we know, there's a lot of things about the Affordable Care Act that are popular. And a lot of those things are popular with their constituents. And so if you take things away from people that they like, what might happen to you? You're going to get fired. You're fired. Yeah, you won't get reelected. And so some of what some of this played out in the midterm elections. So according to exit surveys, healthcare was the most important factor in many of these battleground states and battleground elections. So this coming out from the Trump administration, from the president and his cabinet, is really kind of making some Republican senators and congressmen and women very nervous. So I'll post this because I think this is a really important thing to think about, really the potential impact of essentially repealing the whole Affordable Care Act with nothing in place. And so this article from the Kellogg Family Foundation, and I'll post this on there, shows a summary of the different key provisions, kind of how people are affected and dollars involved, along with the public opinion of the different things. Because we know some things are favorable and some are not favorable. So I'll post this on there so that you can look over this and maybe educate your family or your friends, or just stay abreast of all the possible changes that are happening around healthcare. So like I said, never a dull moment. All right, so we're going to talk about managed care for the rest of the day. I do not have as many interesting stories. I have not worked in managed care, and we actually talked a lot about and around managed care throughout the semester. So we're going to dive a little bit deeper. There might be some things that are more review, so I'll try not to belabor things that we've already discussed. Too much. All right. So the use and the prevalence of managed care has really transformed the U.S. healthcare system. And it really started to take a bigger chunk of how we pay for healthcare, or how it's set up, in part due to kind of the failures of fee-for-service. And the main failure of fee-for-service, which we've discussed quite a bit, is that without controls, costs really can grow in an exponential way. But managed care, like many things, taken to its purest form, is not as popular, and so there was a lot of backlash against it. And so we've seen kind of a change from a really stringent managed care model to kind of a more hybrid over time. So what is managed care?
Basically, you're putting in stricter requirements, and you have less options, but that comes with, because you can plan it out a little bit more, reduced costs.
Yeah. So it's like taking all those four quadrants that we talked about at the beginning, which were financing, insurance, delivery, and payment, and putting them into one thing. So it's a managed care model. Is like an organized approach to the delivery of comprehensive services, and it's to an enrolled set of members. So when you guys were doing case 2, many of you, when you were looking at the different Medicaid programs, you picked ones that were either fully managed care or highly managed care or not managed care. So we'll talk a little bit about how it's grown even in the Medicaid side, but those were for those members. So it's a managed care. It's not available in all places, but it's the idea is through those efficiencies in the management of services, you will cut costs. So it integrates financing, insurance, delivery, and payment within one organizational setting, and it exercises formal control over utilization. And there's a couple different ways that it can control utilization. So just to kind of talk through those 4 quadrants, when we talk about financing, so those are those contract negotiations between the employer or the government, in the case of Medicaid, and managed care organizations. So they're actually in the contracts of how they're financing. around insurance, the managed care organization is the one that assumes the risk for insurance. The delivery of that healthcare is through those contracts. So the contracts are arranged through either employed physicians or with like physician groups. And then payment has a varying degree of risk from the providers. And we've talked about that kind of more generally in the financing week. But if we're talking about a capitation model, which, do you guys remember what capitation means? This is like the original version of kind of how insurance was set up.
Payments. Well, it kind of is.
It is.
It's that plus something.
Yeah, so
Or
it's
whatever the plus is.
so it's a set cost or a fixed cost per patient per unit of time. And so it's paid to the providers. And so say they're going to have they're going to take on the contract for ETSU employees. So they have a fixed amount of money per patient that comes through the doors per unit of time to provide delivery of services. So in a capitation model, the provider has most of the risk sharing. So depending on how they provide care, so they can either end up spending more than what they're getting, or they could do some cost savings. So this kind of goes in direct opposition to fee-for-service, right? So the idea is you have $50 per person in this room. Now, if you provide services above $50, you're going to eat the cost. If you're able to find efficiencies, you might save some money and end up, making a profit. Discounted fees. So this really takes the majority of the risk off the provider. And so what they negotiate is to work with our managed care organization that is covering ETSU employees. They say, we'll give you, this is the original cost for this service, but for this time only, if we do this contract, we'll only charge you 80% of that cost. And so they'll give a discounted fee. So that, again, is the least amount of risk sharing for them, because they already kind of know going in how much each of you will cost the system. And then salaries. So this kind of is a kind of shared model of payment where salaries coupled with bonuses that are, or withdrawals tied to utilization patterns allow some risk sharing. So if you can, as a salaried employee of the managed care organization, if you're able to provide some efficiencies and cut some costs, then you get bonuses. So there is some incentive for you as a provider to be always thinking about cost control. And so kind of the financial structure of the Baylor plan was based on that capitation model that we talked about, where you had a fixed amount of money. A contract practice is a defined group of enrollees. So that really goes into that. You kind of have your boundaries on the people who are in that contract. And so the HMO Act of 1973 was like many of these other kind of CMS projects where they're trying to find ways of innovating to cut costs. So this provided financial funds to help start some new HMOs to really see how these health management organizations, healthcare management organizations worked and looked. So we still have a lot of fee-for-service, but fee-for-service has some flaws that we've discussed multiple times throughout the semester. One is uncontrolled utilization. So we've seen this through moral hazard, where there's not enough skin in the game for the patient, therefore they utilize the services a lot. We see this in provider-induced demand. So if you get money for every diagnostic test, you may run more diagnostic tests because you'll be able to get more money for that. There's also the flaw of uncontrolled prices and payments. So because you're getting a fee for each one of those services, there might be a chance that those services may have an artificially high cost level. So you may be a practice that is setting your costs pretty high, and at the time, the insurers were very passive payers of these claims. They weren't really kind of pushing back on that, but they had to pay for it somewhere, so they weren't going to eat the cost. So what happens if the cost of care keeps going up, but you are a for-profit company with shareholders, so they don't want to lose their profit? Who's going to pay for that? Us. Yeah, your premiums are going to go up. So, so the cost to the person or to the employer was going up. And then with fee-for-service, what we want to kind of move away from is this illness model or disease model, and focus on illness rather than wellness. So if you're going to get money for each service related to illness, there's not this kind of mindset around preventing illness in the first place. So little emphasis on prevention, and then there's also it's lucrative to have patients go into the hospital. So very much looking at it from an illness model versus a wellness. So employers, which is where the majority of people get their insurance from, they started to push back on this rise in premiums. And so part of that was the kind of rise in HMOs, which would, we'll talk about HMOs, really restrict choice of providers. So the employees didn't like that, right? We want our choice. We want to choose between our favorite doctor and don't tell me what to do. And providers, due to the idea that if they're not one of the providers in your network, then they're going to lose those patients. But when premiums were going up at about 12% annually, employers, they just had to do something to cut that, because those services provided of insurance, and that is a benefit to the employees, but at that kind of rate of increases, you're cutting into the profitability of the organization. They may not be able to give raises because the money has to come out of somewhere. So that was the kind of appeal, some of the appeal to managed care was around that. So there are both efficiencies and inefficiencies. So with a managed care organization, putting all 4 of those quadrants under one, you're taking out some of the intermediaries, so that creates efficiencies around insurance and payers. So those are all within the same organization. You save some cost and efficiencies in there. The risk sharing of providers, so that will that will impact provider behavior. So it would lower overutilization through the provider related demand. So that kind of indirectly controls utilization when you no longer are getting this fee for service. You're going to not create so much demand around services that are not necessary, because again, those cost you money to provide them, and you only may have like a capitation or a very specific amount of money that you get for those services, so it might not make sense to financially do that. Gatekeeping, as we know, reduces moral hazard, because now I can't just call up a specialist. I have to meet with my primary care physician and then get a referral. And then kind of from the prevention side, that helps us detect and treat health problems early. So again, that saves the managed care organization money, because you're catching things earlier, and those primary and secondary services are much cheaper than those tertiary, right? But the inefficiencies that we have are that there are multiple plans that providers have to deal with. So they're doing contracts with different organizations, and that is complex. And we know that that kind of complexity leads to having to code things differently or ensure that you're aware of the stipulations of the different contracts. So there's a lot of inefficiencies in that. And then if a service is denied, there's a lengthy appeal process. I don't know if you guys have ever had to go through that, but it is very complex and inefficient around that. But we can see kind of since the early 90s, just the rise in managed care over fee-for-service. So in 93, that's when it gained the larger portion of the market share, and it just exploded to where in the about 10 years after that, it was 95% of the market share. But then mid to late 2000s, high deductible health plans with savings accounts came into the picture, and we're seeing a larger share of the market going to them. So what is just quickly, high deductible health plan?
So that's lower premiums, and basically you're setting aside a certain amount of money. That way, if something should happen, then you can kind of dip into that.
Yeah. So that's the one that has the savings account. So you're like putting money aside. The premiums are lower, but what happens when you have to use the services? The out-of-pocket cost. They're higher, right? So these plans are really beneficial and attractive to individuals like yourselves, like younger people, healthy individuals, people who don't have kids, 'cause kids get sick, and you don't know if it's an ear infection or they need to get tubes put in their ears. Like, those are two different things that can cost a lot of money. But for healthy individuals who, you know, have the ability to dip in if they need to, if they have to go to the doctor, those are lucrative. So once those became an option, they kind of continue to gain traction. But really, fee-for-service is kind of out of the game, right? That's just non-existent anymore. So we'll quickly kind of talk about these cost controls. When we think of HMOs or we think of managed care, the first thing you think of is choice restrictions. And so the most restrictive would be a closed panel where they say, these are the doctors you can see. These are the in-network and these are all you can have. And then you have kind of these open ones where you have, these are your in-network doctors, but if you really love Dr. Smith, you can see her, but here's the cost for seeing an out-of-network doctor. And there's a higher cost to you, but that might be okay to you. And so that gives a little bit of freedom. So utilization, do you think it's, which of those two, an open or closed panel, do you think is better at controlling utilization or managing utilization?
That's the close.
Closed, yeah. Which do you think people like better? Open, right? Yeah. So there is a lot of backlash around complete closed panels. So that's why we have open panels now, because some people will say, I would rather pay $50 to see Dr. Smith than $25 to see Dr. Jones. Gatekeeping, we don't really need to talk about that. It's just really that primary care is that portal to entry. Case management. So we see case management used for really complex patients. And this is usually for those patients who have like AIDS, like major severe injuries, transplants, things like that. And they need someone to ensure the management of their case so that they are seeing the right people, that two doctors are not ordering the same x-rays, so that there are some efficiencies in that, because these are individuals who are seeing lots of different people, and they're very costly patients to the system. Disease management is just taking that case management and having it specific to certain diseases. What kind of diseases do you think disease management is used for?
Or chronic.
Yeah. So we're seeing a lot of complexities with chronic patients with chronic conditions. And this kind of moves beyond just the coordination of care, but also adding in health education. So say you have a patient that is diabetic, you know, there may be education around diet, controlling your insulin, as well as how to identify any issues around your sight or your you know, other possible comorbidities related with it. And that's really just trying to prevent someone from going from, you know, a secondary place, or delay any complications whenever possible, prevent or delay. So pharmaceutical management, and this happens, so there are drug formularies. So there are specific drugs, and these formularies are giant, that are covered by health insurance. And then there may be tiered cost savings. What would that look like?
Like generics versus brand name.
Yeah, so your insurance may direct you towards, the generic version of a beta blocker or something, because that cuts down on costs as well. There's some really interesting, I'll put this up too. So NPR does this series where they just get people to send in their bills from their health insurance, and then they'll pick one and they'll talk about it. This woman, I'm gonna get it wrong. I don't know if she got bit by a raccoon or she got scraped by something, but she needed to get a medicine. Maybe it was a scrape, so she had to get a tetanus shot, or no, it was a rabies shot. She had to get a rabies shot. If you go to the health department, you just go to the health department and they'll give you a rabies shot. She went to the hospital. The health department was closed or something. She ended up getting this ridiculous, huge bill for this medication because it was just not on that formulary. Because if she went to the health department, they wouldn't have billed it to her insurance. They would have just provided it to her at no cost. But there's all these really interesting things that you might not think about when you're like, I might have rabies. I need to get the shot to not, to cure me of it if I have it. So pharmaceutical management, we're seeing these really interesting things though, where pharmaceutical companies are trying to continue to keep their market share from the generic model or generic makers. So they'll reformulate something slightly different, and then your insurance company may not cover that because they'll say there's no real difference compared to the original version, and we have generic. So there's this management around the cost of pharmaceuticals. And then we have utilization reviews. And these are a process of evaluating the appropriateness of service utilization. So you have prospective, which is the decision often to either refer or not, or needs a pre-authorization, requires a second opinion, those types of things to ensure that this is really the course of action that needs to be taken. Concurrent, which is really what Mr. Youngblood talks about a lot, is around decisions about length of stay, discharge planning. That is his world. They're doing this concurrent review around should we discharge someone? How many days do they have left? Are there any special requirements? And then retrospective are really just medical chart reviews. My grandmother has she's been having hip pain, and she went in and she's the cartilage has pretty much gone in that joint, and so she's gonna get a surgery to fill in that area to essentially build in pretend cartilage. And she has lifetime TRICARE because her husband retired from the military. She also has Medicare. And so I was talking to her, and she was very frustrated because she wanted to get this surgery done on X date. She went in, and they were making her go through all kinds of stuff, and she's like, I have these insurances. I've had major surgery before, and I have insurance that will cover it. And so I was trying to explain that probably what's happening is this pre-authorization period where actually the insurance company wants to make sure that this is the correct surgery. But it's very hard to get that across to her, that she has to wait and go through and see another doctor to ensure that this is the right thing, or run another test, or try another medication. But really, that's the real life way this happens. Like, the insurance company is not going to approve this surgery that's going to require at least one overnight stay and home health care for X amount of time unless they know for sure this is the right course of action. And the last is practice profiling. And that's really where, like, the practices are evaluated against their peers. It looks at patient satisfaction, compliance with clinical guidelines, and it provides feedback to change maybe provider behavior to help control, cost and efficiency in care. What do you think physicians or any provider feels about this kind of thing?
Not their favorite.
Yeah, I mean, it's like someone coming in and checking your work and telling you, like, you're doing it well or not well, when it's something that you may have been doing for 20 years. They're mixed feelings about it. Okay, so there's 3 kind of main types. HMO, health maintenance organizations. That was the OG, the original. With HMOs, the focus was on preventative services, having your primary care be the first contact, and capitation. So it really used that. This is the amount per person per service. The use of in-network services with some carve-outs for special services. And so within HMO, there's multiple different models. So the staff model essentially is that the providers are on staff of the HMO. So they're salaried employees. So the HMO has pretty much all the control over the physicians. There's also this idea of convenience, one-stop shopping, so they may be within one building that people like. It's kind of, the disadvantages are the cost for salary plus benefits. I mean, that's a pretty big investment in your physicians. And so that makes it hard to expand into new markets because you essentially have to buy up a bunch of practices or start new practices to move into another market because your market share is really where you have your salaried employees. And then there's just very little choice for people within that network. So for the people who have that insurance. So it's not the most popular. It's actually the least popular. The group model is that you contract with a single multidisciplinary group. And then the network model is just you kind of taking the group model and expanding it to, you contract with multiple physician or provider groups. Some of the advantages of those kind of models are that there's no salary or facility expenses, so you're not actually paying for the building or the provider's benefits and salaries. if you have really well-known provider groups, that helps your prestige more. Employers will want to contract with you because you're working with one of the prestigious groups. What are some of the groups that you can think of in our area?
I think it's more like the cardiac associates groups.
Mm-hmm.
I don't remember the name, but
Anyone you can think of? ETSU, Physicians Group.
Yeah.
ETSU Physician Group, State of Franklin, and they provide all kinds of different services. So if your HMO covered, like if you have a contract with State of Franklin, people are like, ooh, I love State of Franklin. Oh, I already have a doctor who's in State of Franklin. I will work with you. Some of the disadvantages are that you have less control, right? Like now you're contracting, so you don't have the same control over utilization and control as before. And then, as a HMO, when you have the network, that adds some complexities and inefficiencies because you're doing these contracts with different groups with different contractual obligations. You have to have different groups, different contracts with hospitals, so like it just infinitely gets more complex. The next model is PPO, so preferred provider organization. So then that's really kind of addressing some of the backlashes that people had against HMOs. You contract with preferred providers with a discounted fee arrangement, somewhere between 25 to 35% of a discount of charges. PPOs allow for that open panel, which people like. There's little or no risk sharing since it's discounted fees. And no gatekeeping, but then there's still the use of prior authorization. I mean, that's going to be in all of these. For hospitalization or for kind of more expensive services and procedures. And so we'll see in the next slide, I think, or in 2 slides, kind of how the PPO has become the preferred and most popular managed care option. The third is POS, which does not stand for what you might think, but point of service, which is really just a cross between an HMO and a PPO, where it has some HMO features associated with utilization controls and capitation, but allows for an open plan option from the PPO. Okay, so we've really pretty much talked about these. Fee-for-service has really, really substantially declined. There've been increased cost sharing by employees. So as costs have gone up, and before the Affordable Care Act, we were seeing costs go up. That just means that the premiums that the employees were paying increased. But we've seen these high deductible health plans that have come into the market, and those have taken some of that managed care market share. So For Medicaid, the Balanced Budget Act of 1997 allowed states to enroll Medicaid beneficiaries in managed care. And I think many of you guys picked Tennessee as the state that you were going to kind of deep dive. And many of you noted that Tennessee was one of the original managed care states to utilize managed care for all their beneficiaries. Now, what about with Medicare? Is there a managed care option? And if so, what part is it?
Medicare Advantage, right?
Mm-hmm. Yeah. So there are two options. You can do the fee-for-service or Medicare Advantage or Part C. And so we saw managed care Advantage kind of grow, and I think because of changes in Medicare financing, they're not getting as high of a states. Medicare Advantage plans are not making as much money, so we're not seeing as many of them. So, as you see, kind of from a kind of employer-based level, we can see that about almost half of employee-based health plans are PPOs, but that almost a third is health high deductible health plans with savings account / savings account. So it'll be interesting to see how this continues to evolve. POSs were more popular than HMOs until HMOs started to kind of loosen their restrictions on their panels, and then just I think due to longevity, HMOs have regained some of that market share. And as a kind of what I mentioned before, PPOs dominate the employer-based one. Plans, as far as health insurance exchanges, must comply with Affordable Care Act mandates, and this has an asterisk, subject to change with administration changes. So any of this is subject to change with these changes that we're seeing. Under Affordable Care Act, they were to include essential health benefits and comply with the medical loss ratio requirements. And so for Medicaid, over 70% of their beneficiaries are in managed care. They use the primary care case management. It's direct contracting with providers by states on a fee-for-service basis. But the beneficiary must have a primary care physician, but open access is allowed. So that's the model that you see. The problem with this is that in some geographical locations, managed care is not available. So, that makes up for that difference in states that don't have it across the board, where only some or most of their Medicaid enrollees are in a managed care option. So for Medicare, the option of Part C is there. These are capitation risk contracts. So when that capitation went down, a managed care pulled out. But then CMS rolled out payments based on risk adjustments between 2003 and 2007, which caused an increase in enrollees in the subsequent years. And in 2013, about 28% of Medicare beneficiaries were enrolled in managed care. And so, again, you can see that it's not required, but the Affordable Care Act aims to reduce payment to managed care organizations, which we've seen participation kind of start to decline because the cost sharing, again, the managed care organization is going to make the money, so the beneficiaries or enrollees are going to have a higher cost, so they're not going to see the benefit of doing Medicare Advantage over a fee-for-service in the long run. Nope. Okay, so what have we seen? How has this actually impacted those three things: cost, access, and quality? So the original cost containment was really strong, so early successes, but there was backlash from both the providers and the consumers. And so because of that, those closed panels became open panels, so we never really realized the full cost containment potential. Excuse me. So it has had some impact on cost, but really that original idea of controlling cost by controlling utilization of closed panels, we just haven't, that never was realized because it was very unpopular. Impact on access. So because of the focus on prevention and gatekeeping through primary care, there is greater access, which may have been responsible for lowering some of the risk for preventable hospitalization. So through managed care, you have that gatekeeper and like primary role of primary care. So a major factor in access, though, relates to lower reimbursement rates for Medicaid. So what does that, so if you get a lower reimbursement rate for a Medicaid patient compared to a private pay patient, how's that going to impact Medicaid enrollees?
Access, because providers want to attend to patients that we don't want.
Yeah. So it kind of discourages providers to take on Medicaid covered clients. So they'll have a mix, a payer mix, where only a portion, and a smaller proportion at that, is Medicaid compared to other patients, because for the same service they get less money, and they are businesses. So that, like you said, decreases access. So they may have a primary care provider, but they don't have an opening for 2 months for them to go see them. So that impacts their true access. And then as far as quality, overall quality of care for managed care organization plan, so is equivalent to traditional indemnity plans. So there is evidence of somewhat better quality of managed care. But that differs based on if your managed care organization is for-profit compared to non-for-profit plans. So like it's not across the board, it depends kind of thing. We already talked about backlash. So kind of the aftermath of the backlash, we've in the anti-managed care laws produced, essentially managed care had to roll back a lot of those cost containments. So there's not that same control over utilization, and they now work much closer to develop better relationships with physicians and other providers. I mean, this is the model that we're essentially living under now. It's not fee-for-service, but it doesn't look like the original managed care was intended to look. Okay, any questions before we kind of touch briefly on integration models? So we're going to kind of shift from managed care to integration.
I have a question. Is it safe to assume that capitation will become a bundle payment?
Yeah, so bundle payments are, capitation is the underlying funding or payment scheme for bundle payments. So, and I believe that's your third case. You're going to talk about bundle payments. So it's like a capitation that's across the whole service. So this is the cost or the amount we will reimburse for this thing. And it's across those different entities though. So instead of a capitation at the provider level, it's at the procedure level. Good question. Okay, so when you think of integration of delivery system, what is something that comes to your mind, students who live here in East Tennessee and maybe Southwest Virginia? What was a big integration? Valid, right. The big one. So there are different kinds of integration strategies that we'll talk about. But the valid one is an integration that would fall into mergers and acquisitions, right? So that strategy was integrating existing assets. So what happened? What were as they call them, the legacy systems?
The Mountain States and Belmont.
Yeah, so we had Mountain States Health Alliance and Wellmont Health Systems. And one of those systems was in the market to be acquired. And so during that process began this multi-year process for these two systems to become one. And a merger or acquisition is the most complete kind of integration. So there's a spectrum. So that is like in your head, these two systems became one. And they not only became one, they changed their name and became a new system called Valid. So when we think of integration, this is a network of organizations that provide or arranges to provide a coordinated continuum of services to a defined population. And then they are willing to be held clinically and fiscally accountable for outcomes for that population. And so you can integrate your systems, and that's really integration of existing assets, but it also can provide an opportunity for diversification. So additional new services that the organization has not offered before. So by merging and kind of eliminating some inefficiencies or duplication, that might provide an opportunity for a new system to diversify and add new service lines. So we have mergers and acquisitions, but you might have a joint venture, which kind of plays into that diversification. So your system might have a joint venture with another system that provides services that you don't currently provide. So this allows diversification, but you're not going to be competing. Say you have a system that doesn't currently have pediatric services. So you might go into a joint venture with a system that has pediatric services. This is a win-win because you are diversifying, but you're not going to be competing because they don't have providers that are going to be competing with yours in the non-pediatric realm, for example. So that would be a joint venture. Alliances are even less formal as far as ownership. So agreement to share existing resources without ownership. And a network would be multiple alliances. So there are two kind of service strategies, either horizontal integration or vertical. So think horizontal. So if you're integrating across, so you're expanding across like a geographic region, but you're not diversifying. So that would be like you are a health system that is in Middle Tennessee and you want to expand into Northeast Tennessee. So you would be doing a horizontal. You would be expanding your system geographically, but not necessarily diversifying. Vertical would be to add services along a continuum of care. So you would be deepening those or expanding vertically by providing additional services. So kind of you're a visual learner thinking of it that way. There are 3 basic forms of integration. Management service organizations. They supply management expertise, administrative tools, and information technology to different physician group practices. So this kind of integration is used typically by smaller groups who can't employ full-time managers. So this is a way for them to get access to services that they don't really have the capacity to hire those managers. Physician hospital organizations are an alliance between a hospital and physicians. And so this is kind of trended more towards actually those physicians becoming the employees of the hospital, so not an alliance, but actually salaried employees of the hospital. Just due to changes in kind of the culture and reimbursement. So it costs a lot to have a practice. Reimbursement is going down. There are demands and requirements for kind of costly things like EHRs and EMRs, and those are very costly for physician groups to have to take on when you could just work for the hospital system, and then they already have their EMR, and they also will pay you a salary, and you don't have to worry as much about if there's a no-show or not. So younger physicians are preferring this model. So I think we're going to see more and more where you're going to see less physician-owned practices. And then the last is provider-sponsored organizations. So then essentially the risk-bearing entity that competes with managed care organizations. So this would be like self-insurers. So Valid may self-insure for their employees. So since they are the risk-bearing entity, they may say, you know, we are now Valid. We're going to create, essentially, we're going to look like a managed care organization and just cut out the middleman. The problem was, this seemed really like a good idea because this is even taking out that extra layer of middleman of managed care. But they've actually failed quite a bit because that insurance function of being able to really do that well, the lack of expertise within those organizations like the hospital systems, they just were not able to make that work. And actually, Mountain State Health Alliance got rid of their PSO a couple years ago. Okay, so this is a nice little graphic that shows kind of how the different integrative strategies look, and then the different service strategies. So you see integration of existing assets. So we see that acquisition, where one entity is acquired by another. A merger is the fusion of two organizations into a new one. And then you see the sharing of existing resources are those alliances and networks. Versus for the formation of new assets, that's that joint venture. And then the vertical versus the horizontal. So, is Valid an acquisition or a merger?
So, merger.
Who would be the acquirer?
Mountain State.
So there's rarely a true merger where they're equals coming in. There will be, so they may call them, they'll say this is a merger, and it is two becoming one. But there was a in the negotiations, there were power differentials. Which was the system that was looking to be sold? Wellmont. So that does change some of that negotiations. Why did they choose to become one versus because they were fierce competitors. Like they were fierce competitors in this market. Why would they choose to become one? Why would you let your competitor acquire you?
Because weren't they bankrupt? Like they were going to be sold or closed down anyways. And instead of being like outsourced from other places, that Mountain States wanted to just take over it.
There's something to be said like about having an acquisition from like someone from Dallas or someone from California or some larger market. Like, would they really know your patients? Would they know your providers? Do they know East Tennessee and Southwest Virginia? No, they have shareholders and boards and all these competing interests that are not located here where we are. So I think that's a big one. So it's Mountain States was a known, right, versus an unknown. Why did the states allow them to do this? Because they essentially created, for all intents and purposes, a monopoly.
Because they had like agreements in place that they're gonna, improve the health of the region without, and then also I think some cost ones too that they have to make sure they don't abuse like a monopoly would.
Yeah, so there's the two states who are involved. There's a COPA in Tennessee, and then there's the different name in Virginia. But essentially the states, for them to say you can have this monopoly, you have to meet these certain qualifications. And it's a lot of things. And they are around kind of community benefit. This has to benefit the people of East Tennessee and Southwest Virginia. And it has to also be watched and monitored for issues around cost, so that we're not all of a sudden, since the only game in town is ballot, that they can increase cost over year at a certain rate for services. Okay, and then just my last slide is on accountable care organizations. These are integrated groups of providers who take responsibility for delivering services to a defined group, a defined population. So essentially, there's the risk. There's a lot of risk as far as they take the responsibility of improving health. So if the ACO meets their metrics of health improvement, they get money back. If they don't get money back and they lose money. So it's very it's risky, and ACOs, all of the different entities under them, share that risk. They're not as there's a lot of CMS money to do some pilot or test ACOs. So we saw a lot of ACOs originally, kind of organizations coming on, writing proposals, getting funding to be ACOs, when there was no risk sharing. When that funding went away and they had to start showing improvements on health, and if they didn't, they were held accountable and they lost money, you're seeing less of them, because it's really hard to take on this risk for all the reasons we know in public health about complex patients and like the social determinants of health. There's a lot of things outside the walls of those organizations that it just made it hard to be successful. Okay, that's all I have for you guys this evening. We will see you next week.